Hello and welcome to the topic squamous cell carcinoma in the dermatology module. By the end of this topic, you should be able to define squamous cell carcinoma, explain the pathophysiology of squamous cell carcinoma, outline the causes of squamous cell carcinoma, outline the classification and clinical manifestations of squamous cell carcinoma, outline the investigations that can be done, discuss the principles of management, and discuss the complications and prognosis of squamous cell carcinoma. Let's get started. Squamous cell carcinoma, or SCC, is characterized by abnormal accelerated growth of squamous cells, which is the cell lining of the outer epidermal layer of the skin. Squamous originates from Latin squama, which means the scale of a fish. Squamous cells got its name because they are thin and flat, making them look like fish scales. Our skin is made out of epidermis and dermis. Epidermis consists of stratified squamous epithelium, which are keratinocytes in progressive stages of differentiation. Layers of epidermis are stratum corneum, the absorptive layer, stratum lucid, which is only found in thick skin, stratum granulosum, also known as granular layer, stratum spinosum, the prickle cell layer, and the germinative layer known as stratum basilae. Epidermis functions as a physical and biological barrier to prevent penetration by irritants and allergens. Dermis is the inner layer of the skin. It is much thicker than the epidermis. Its function is to protect and cushion the deeper structures of mechanical injury, providing nourishment to the epidermis and for wound healing. Overall, the skin is essential for protection as it forms a protective barrier to protect us from mechanical, thermal, and other physical injuries, as well as harmful agents, excessive loss of moisture and protein, and harmful effects of UV radiation. The skin is also needed for thermoregulation by altering blood flow through the cutaneous vascular bed. And lastly, the skin is the organ that provides sensation to our body. Exposure to prolonged and excessive UV radiation is the major risk factor for squamous cell carcinoma. Mutations of the gene has found to cause squamous cell carcinoma formation, one of the gene in P53 gene. P53 protein function by stopping cells with mutated or damaged DNA from replicating, and when mutation happens, it becomes non-functional and cells with damaged DNA due to UV radiation will be allowed to replicate. Another gene mutation is deletion of tumor progression loci 2. With the combination of these gene mutation, epidermal keratinocytes acquire anti-apoptotic properties, leading to frequent mitosis. Causes of squamous cell carcinoma are UV radiation, including sun and tanning bed. Human papillomavirus infections have found to be associated with this tumor. Genetic causes include mutation of P53 and TPI2. Actinic keratosis and melanoma are preceding skin lesions that might lead to formation of squamous cell carcinoma. Bowen's disease is squamous cell carcinoma in situ, which predisposes the individual to malignant squamous cell carcinoma, lasting long-term exposure to cancer, causing chemicals such as tar in cigarettes, increasing the risk of squamous cell carcinoma. Squamous cell carcinoma precursors are actinic keratosis and Bowen's disease. AK is usually ill-marginated, and with scaling, rough papule or patches are seen on the face, neck, dorsum of the hands, forearms, upper chest, back, and scalp. In situ squamous cell carcinoma is also known as Bowen's disease. It is often asymptomatic, and signs of Bowen's disease include erythema, well demarcation, scaly patch or plugs, and slowly enlarging. It is a low-grade type of squamous cell carcinoma. Rarer subtypes include clear cell carcinoma, spindle cell carcinoma, and squamous cell carcinoma with single-cell infiltrates. Spindle cell squamous cell carcinoma has raised or exophytic nodules with spontaneous bleeding and central ulceration. If it is ulcerated or nodular, it is most likely to be clear cell squamous cell carcinoma. Invasive squamous cell carcinoma has infiltrative cells passing through the basement membrane into the dermis. Squamous cell carcinoma that are unrelated to solar exposure include de novo squamous cell carcinoma, verrucous carcinoma, and lymphoepithelioma-like carcinoma of the skin, or LELCS. This carcinoma may range from asymptomatic to presence of ulcers or reddish skin plugs. Such lesions are slow-growing and more frequently found at the back of the hand, scalp, lip, and superior surface of the pinna. Upon examination of this primary lesion, it is often ulcerated with hard and raised edges. There will be the presence of telangiectasia. Actinic keratosis is seen, which is the rough scaly patch on the skin which develops from years of sun exposure. Squamous cell carcinoma might result in chronic draining sinuses. Suspicion of squamous cell carcinoma should arise when patients complain of a nodule that has expanded with central necrosis, which eventually evolves into ulcers covered by red growing plaques. The lesion frequently scales and easily bleeds. Investigations of squamous cell carcinoma involve the use of dermatoscope, which will show hyperkeratosis. Incisional skin biopsies show histopathology of nuclear atypic, irregular nest, cords and sheets of neoplastic keratinocytes which invade the dermis. CT scan is needed to access surrounding tissue invasion such as soft tissues, bone, and lymph node metastases, while MRIs are used to evaluate vital structures including neural and vascular invasion. Medical therapy is used as adjuvant and for patients who are not eligible for surgery, such as elderly and immunosuppressed individuals. Radiation therapy is used to improve loco-regional control and for those who are unable to undergo surgical excision. Chemotherapy is used as adjuvant therapy. Specific drugs are oral 5-fluorouracil and epidermal growth factor receptors inhibitors. Surgical therapy is the definitive therapy for squamous cell carcinoma, and it is to reduce risk of metastasis and recurrence. Low-risk squamous cell carcinoma which are present at the trunk or extremities can be removed by electrodesiccation and curettage, while invasive squamous cell carcinoma requires surgical excision and most micrographic surgery. To prevent the development of squamous cell carcinoma, one should wear appropriate sun protective clothing and use broad-spectrum sunscreen with at least SPF 50. They should avoid intense sun exposure too. Acute complications of this carcinoma are local invasion, pain, loss of function, and poor aesthetics, while chronic squamous cell carcinoma will lead to metastasis and eventual death. Squamous cell carcinoma has high risk of metastasis even at time of presentation. Poor prognostic factors are perineural invasion, poorly differentiated lesions, lesions thicker or greater than 2 mm, lesions thickness greater than 2 mm, and lesions on the ear, scars, and on the lower lips of the mucosa. Immunocompromised individuals have poorer outcomes too. Let's summarize what we have covered so far. Squamous cell carcinoma is the abnormal accelerated growth of squamous cells. Squamous cell is the cell lining of the outer epidermal layer of the skin. UV radiation, p53 gene mutation, and deletion of TPI2 gene causes epidermal keratinocytes to acquire anti-apoptotic properties and leading to frequent mitosis. It presents as a small, rough, scaly nodule with central necrosis, ulceration, and bleeding. Dermatoscopy and skin biopsy are essential for the diagnosis, while CT and MRIs are used to access metastasis. Surgical excision is the gold standard, and the technique used is most micrographic surgery. We have come to the end of this topic. Thank you.